Additional witnesses in support? Seeing none. Witnesses in opposition?
Good afternoon, Mr. Chair and members. My name is Fred Noteware, and we are representing the Pharmaceutical Research and Manufacturers of America, otherwise known as PhRMA. And to my right is John Murphy, legal counsel with PhRMA, who's here to answer technical questions. And we're here in opposition to AB 463. Aside from the operational difficulties to be faced and costs to be borne by the drug companies in complying with the mandates of this bill, we are really at a loss as to what will actually become of all the information to be reported. The requirements for information are significant on the companies, both large and small, and we have to ask to what end. Even as amended, companies will be forced to submit reams of data, and as specified on page 3, line 21, this information has to be verified, quote, by a fully independent third-party auditor prior to filing. What will everybody do with all this data? No one has ever really indicated the utility of these reports. And actually, I think most of the committee members know, companies already submit considerable information in the aggregate in their SEC filings. Why isn't that information adequate for the purposes of the bill? In some cases, the number sought by the bill will be impossible to ascertain, since the cost of developing one drug cannot be separated from the cost of a similar product, since sometimes that similar product will have failed in the clinical trial process. Drug development is often in the disease state, not by drug category. Clinical trial costs are closely guarded. This bill would seek information about them, and each company handles clinical trials differently. The data the bill is seeking could enable one company's competitor to reverse engineer these numbers and gain an unfair advantage. The committee well knows that drug spending accounts for about 10% of each healthcare dollar. Our industry stands by this number and feel proud of the value that we are bringing to our patients. While Mr. Chu is right, drug spending has gone up in recent years, but so have other costs of other elements of the healthcare system. And we still remain right about 10% of the healthcare dollar. Why are things going up? More people are covered. More people are getting services, and the good news is they're getting care. Physician care, hospital care, prescription drugs. Remind the committee as well that in California, anywhere from 80 to 90% of all prescriptions dispensed are generics. That's not our business. And so we're talking about actually a smaller and smaller component of what's actually filled. And one more thing we would point out to the committee, that there's a lot of support for this bill from our friends in the managed care communities, but remember that it's the managed care companies that still hold all the cards when it comes to patients actually having access to medicines. The plans through their treatment policies determine with clinicians, and this is appropriate, when to initiate treatment with patients, and equally importantly, the plans have become quite masterful in utilizing their tools such as fail first, prior authorization, formulary placement, tiered copays, and step therapy to limit access to medications. So, as I said before, Mr. Chair, we stand very pleased at our role in providing value to the healthcare system. These companies are innovators. They are innovators. They're bringing new products to market. If they don't, they will go out of business because their product will go generic. And in order to survive, they have to continue to innovate. We happen to believe that's a good thing, because we're bringing new therapies, new cures to the market. So with that, with all due respect to the author and the supporters, we would urge a no vote. Thank you.
Good afternoon, Mr. Chair and members. My name is John Doherty. I'm Vice President and General Counsel for TechNet. TechNet, as many of you know, is an association of technology and life sciences companies. I'm here in opposition to the bill because, frankly, the focus is rather chilling. and something that I think we should all be nervous and worried about. California is home to one of the most amazing research and development engines in the world. We have created life-saving drugs. We have changed the way that people get around. We have changed the way people access and store information. And while the bill is posited as an effort to make things level and fair across the healthcare playing field, it's really not. That's really not true. The fact is that this bill focuses in on and creates a very onerous mechanism for research and development costs. It is true there is an awful lot of reporting that goes on in the healthcare space, but usually that ends at what the cost of the service is. How much does the doctor charge? What does the hospital charge for the MRI machine? Not how much did they pay to transport it there, get it there, who built the MRI machine, how did they come up with that? The focus is on what's driving the cost. And frankly, these drugs, while some of them are individually expensive because they are short courses of treatment that cure diseases, and rather than going on a lifetime of drugs that cost hundreds and hundreds of thousands of dollars, do it in a very quick area, and so to recoup those costs, those high prices are charged. But you know, this bill, unfortunately, is one-sided in that it doesn't look at the outcomes, it doesn't look at the alternatives, and frankly, for those reasons, we think that the bill is going to create a system that chills the desire of companies to do research and development in California, and we hope that you will consider those concerns and respectfully ask for your no vote.
Thank you. Additional witnesses in opposition.
Greg Herner on behalf of the California Healthcare Institute and the 275,000 California-based employees in this innovative industry. We oppose this bill.
Jimmy Jackson, Biocom, in opposition.
Jennifer Snyder on behalf of the Biotechnology Industry Organization in strong opposition.
Donna Kaler with Pfizer in opposition.
Barbara Morrow with Astellas Pharmaceuticals also opposed.
Flo Conn with AbbVie in opposition.
Gavin McHugh on behalf of the California Manufacturers and Technology Association. We're also opposed.
Chris Rosa on behalf of Bayer in opposition.
Erin Norwood on behalf of Boehringer Ingelheim, also in opposition.
Michael Hawkins representing Celgene in opposition.
Katie Tinney with Biogen in opposition.
Jennifer Stoll representing Allergan in opposition.
Matt Back representing Amgen in opposition.
Anne Murray with Bristol Myers Squibb in opposition.
Jeffrey Leacox Greenberg Traurig on behalf of Novartis in opposition.
Thank you. Questions from members?
I just have a comment.
I'm glad the topic's so easy.
Assemblymember Lackey?
Yes, let me just make just a couple comments. I think that this is a very difficult bill for me to align myself with, because I do believe that, and I do completely support the transparency piece, that I believe that this industry needs to be a bit more transparent. However, I believe that the bill is too draconian in its regulatory demand. I think it goes over the top, and I think that some of that will not measure what really drives the cost. And I think that's what we need to focus on in order to be effective in doing what the bill designs to do. And for that reason, I probably am not, in this form, going to be able to support it at this point.
Assemblymember Burke.
You know I'm struggling with this. But I want to thank you. I want to thank you for moving this conversation forward. Clearly, prescription drug prices have gotten exorbitantly high, and we do have to address it, and I'm glad that we're having a conversation to do that. However, what I am concerned about on this bill is that although I support as well transparency, and I'm always a huge proponent of transparency, I am concerned that this transparency isn't getting us where we really need to go, which is in finding a solution to the pricing issue. And so my question is this. In the transparency as you have defined it here, is there any place where we discuss, for example, my understanding is, and please someone up there correct me if I'm wrong, that, for example, the VA gets high discounts or Medi-Cal gets tremendous discounts as a result of their bulk purchasing. Is there anywhere in this bill, and they get rebates and things like that, is there anywhere in this bill where we are given a guideline as to where those thresholds may be so that this actually is a tool, not just an opportunity to be invasive? And by the way, I do feel like the pharmaceutical companies kind of got what they deserved with this bill because we could never get a real answer as to why the prices were so high. But I don't want to just poke the pharmaceutical companies. If there is a tool that comes from this, I would see it as an opportunity. So that's really my question.
If I could respond to that. First of all, Member Brooke, thank you for your consideration. I want to just take a moment and thank each of you because I know many of you have been really thinking about these issues, and they are complicated. And I think one thing we can all agree on is that the prices that we have seen are skyrocketing, and they could threaten to cripple our state government budget, and they certainly, as you've heard from representatives of thousands of businesses as well as labor unions, threaten to cripple many organizations. So I think we can all agree that we need to do something. And what I want to do with this bill is really move forward a conversation so that we can get some information. Now, Ms. Burke and I had a conversation about this just a few hours ago about her very good suggestion that we consider asking for more information about the different kinds of pricing schemes that are negotiated with by the industry. Because I think, as some of you may know, when the industry negotiates with Medicare or with the vets or with our prison system or with local city health departments, there are different prices and different rates that apply, just as is the case when they are in England, France, India, or Asia or Africa. From our standpoint, though, as policymakers and consumers, this is completely opaque. There is no information about this. In fact, I've been working on this issue for a number of years when I served on a local county board of supervisors, and we were told that we literally were not able to get any information about any prices, even those negotiated with government. And so my question for all of us as policymakers and also for the industry is, if the suggestion is that more information, this kind of information may not help, what information will allow us to get to different prices? Because we have to get a handle on this. And I'm very willing to consider amendments to adding the type of data that you were suggesting into this ordinance so that we can have a law that will get the data that we need to really move this conversation forward.
Mr. Nowhere, did you want to comment on this point?
Very briefly, Mr. Chairman. Thank you very much. I just point out, I think as the analysis accurately points out, in the case of Sovaldi and Harvoni, the discount has been noted at 46%. So, the system is working. Companies are developing drugs, and they're negotiating significant discounts with large payers like Medi-Cal and on the private side as well. Thank you.
Mr. Luisos?
Yeah, thank you, Mr. Chair. In response to the 46% discount that was offered by Gilead Sciences, the percentage is significant. I just would ask members of the committee to put it in context. With the sticker price of Sovaldi being at $84,000, the company that marketed the drug actually did not do the R&D on the drug. It was done by a predecessor company named Pharmaset. And we know through the Wall Street Journal that Pharmaset was going to sell Sovaldi for $36,000 per treatment cycle. Imagine the impact of the discount if it was marketed and sold at that price.
And if I could just add to that, imagine the $300 million that we don't have colleagues to spend on other things. We all talk about needing to backfill all the cuts to Medicaid. That amount for that one drug would fill it in. And Gilead made $10 billion this past year on that drug.
Assemblymember Bonilla.
I guess I'm trying to get to the usefulness of data, and I understand. I think Mr. Noteware testified about SEC filings. What is the difference between that information and the information that you're asking for, beyond the fact that I guess you want a breakdown by drug? Is there any other significant difference between the already public information? And I think there is an opportunity to make all of those filings much more transparent, accessible, and meaningful to us here in California. But is that what the difference, that you just want the actual drugs?
Well, so first of all, there has been a discussion about the data that's already publicly available in SEC and other security filings. And the fact of the matter is, when I had conversations, and good conversations with the industry about that, apparently that information is out there. It's been very difficult for my staff and for other consumer and other health advocate groups to actually ascertain that. And so part of what I'm hoping with our bill is that it makes it easier for all that information to be aggregated in one place, so we understand where that data is. I did a number of weeks ago had requested to understand what data is out there, because as far as I can tell, there's not much data on these cost issues. But if there's a way to facilitate that again through our bill, we would very much appreciate that. Now, that being said, your question also touches on something else, which is there merit in having data around specific drugs? And the fact of the matter is, when you have drugs that are priced at a certain level, let's take Sovaldi, it's important for us to know whether a company made $10 billion and spent $50 million or spent $900 million, because I think that influences our thought as to whether that price is appropriate. We have heard, and certainly in the testimony around Sovaldi, that the pricing of that particular drug was not based on cost. It was based on what good is provided to society. If that is the standard, rather than, for example, the state of California spending $150 million on measles vaccinations, that cost justification could be responsible for price points that would be billions and billions of dollars. So what I'm getting at is it's helpful to know this information on a drug-by-drug basis, and that's why we structure the bill the way we did.
And just to follow up on that, I mean, I would like to hear from the opponents on what information is out there and how can we make it useful. But before, just to address that issue, that's the hepatitis drug you're referring to. I mean, I think there is a difference when someone has a cure, because otherwise, you could take a drug your entire life and then you're saying you're paying off the research, right? Because people are taking it forever. Whereas if you're giving someone a cure over 12 weeks, how are they going to recoup all their investment in research? Because once you're cured, we're not going to have endless numbers of patients that are going to, pay that off over time. So that's just my thought on that one. But could we hear from the opponents on this issue of what information is out there and how can it be used, and is there a way to make it more transparent and usable for us on this issue of price gouging or profits or whatever it is we might be concerned about?
Sure. Assembly Member, Mr. Chairman, my name is John Murphy from Pharma. So there is a considerable amount of information that SEC filings provide, and some of that is on a per-drug basis. Most companies can report on a per-drug basis their annual revenues, but where it becomes far more complicated from a per-drug perspective, now, there are some companies that only make one drug. So this conversation doesn't include those companies, but for other companies that have a portfolio of drugs, most of them report things like R&D spend on a company-wide basis, and there's reasons for that. For one, is companies generally don't conduct R&D on a per-drug or even oftentimes a per-disease state basis. Companies may do ongoing R&D for their approved drugs in patient populations that take multiple drugs, or in patient populations that take competitors' drugs plus their drugs, and all of those costs get folded into the overall company's R&D budget. They also outsource R&D to universities through grants, and that's why it would be tremendously difficult, and quite frankly, I think in the view of many of the compliance lawyers at our companies I've spoken to, present a fair amount of enforcement risk if they were to try and estimate sort of what one drug's R&D costs were and report that to the state of California, which would then be public, wherein other estimates may come out in SEC filings that could be extrapolated differently, and therefore there's enforcement risk for the companies. The same would go for clinical trial costs. That is something that is put into R&D costs that you see in the SEC filings, and that's probably an even more problematic cost estimator for a single drug, because you may be running multiple trials in multiple countries within multiple patient populations in a disease state for a couple of biomarkers or a couple of endpoints for a couple of molecules. And
okay. I kind of get the idea of all the reasons why you can't do it. Is there what can you give us? How can you help us achieve more transparency and more usable data? Because data is only as good as we can use it. And I completely understand your point that if what gets reported is not even really accurate or indicative, or it's too hard to figure out, I don't know that we're getting where we need to be. But what can you, from what you already have made public, or what can you add to it? Well, that would help us.
It would be hard to say what we could add to it without I would suspect that would be a company by company determination. But to answer your question,
could you report it here in California?
I would suspect that there could be reporting around things like revenues per drug. Really, there's a tremendous amount of financial information in an SEC 10K filing. So for the moment, I'm only speaking about publicly traded companies. There are a swarm of privately held companies, mostly in California, that have a lot of innovative products that don't make any of their books public to the SEC because they aren't publicly traded. I think in that case, there's a much more difficult road to hoe in asking a venture capital-backed biotech company to open their books to the state. But most of the companies I represent are publicly traded. There's a lot of information about research and development costs. There's a lot of information about sales numbers and general selling and administrative costs that are contained in SEC filings. And we would be happy, I think, to have a conversation with Assembly Member Chu to talk about how those things could be better flushed out for the state. But it's I think specific per drug. In the case of even in the case of a company that only has one drug, one company has been brought up quite fervently here. They have significant amounts of drugs in their R&D budget that have failed, so those are all included in that as well.
Well, I have a lot of questions about the bill. I'm going to support it today, but I do hope we can keep talking about these issues. I'm not convinced that what we're asking is going to achieve the outcome we want, and so I'll reserve my right when it comes to the floor to see if we've worked more on this bill.
Very much appreciate that, and I in my last conversation with Pharma, I had requested to see if there was a way to gather all the information that's out there, because frankly, if any of you have tried to take a look at it, it's very hard to discern. So I'm happy to continue conversations with the industry on how that could happen.
Assemblymember Wood.
Thank you, Mr. Chu, for bringing this forward. Spent a long time this weekend thinking about this, and it actually, for me personally, brought back a pretty bittersweet memory. 20 years ago, my father had been undergoing a lot of cancer treatment, and we were faced with a challenge of a potential drug that could help him stimulate his immune system, and the cost was $1,000. And we bickered with the insurance company for weeks for permission to get that drug. It ultimately improved the quality of his life. He succumbed from cancer months and months later. But that weighs heavy on my mind as I look at this particular issue. This becomes very personal very quickly, and I suspect there are others of us on the dais who may have similar experiences. There really are no good guys and no bad guys here. There are no angels or no demons, but there are potential winners and there are potential losers. And what you're seeing in this room is a battle of titans, in my opinion. Fundamentally, I think on this committee, I believe the conversation should be about policies that improve health in California, health care. But since the Great Recession, we seem to have devolved to a point where all the conversations are about money. Who makes it? Who spends it? Who wins? And who loses? The high price of these new blockbuster drugs are of great concern. The irony here of this is that if you're incarcerated in a state prison, or you're a Medi-Cal patient, you may have a better chance of actually getting a drug like Sovaldi to cure hepatitis C than if you're insured by a private insurer. Even small increases in the potential cost of a drug raise strong and immediate opposition from health plans and even the Chamber of Commerce. You'll see that later today, regardless of the potential good for patients. If a drug came out tomorrow that could cure diabetes, I suspect that health plans would make that drug very difficult to get to because of the high cost. You'd probably have to try Tylenol or ibuprofen, some new diet, before you could even get close to a drug that might save your life. A patient who might be cured of hepatitis C might be a patient in a different plan next year. So that original plan has been financially wounded by the cure of the disease, and the new plan reaps the benefits of that. My preference here would have been a select committee to address these issues over a longer period of time, but I know from personal experience that even suggesting that scares the heck out of some people. So instead, with limited debate, we're asked to move a bill that may ultimately have significant consequences, some of them unintended. In the end, patients and providers are caught in the middle of a battle of titans on both sides. Patients who may struggle to get medications that could save their lives or dramatically improve their lives, and providers, well, pretty much anything that affects the profits of insurers is taken out of the hides of providers, further demoralizing our doctors. You need no greater evidence of the dissatisfaction of doctors than recent surveys. In 2008, only 6% of doctors described morale as positive, and quite frankly, that isn't good for patients. More recent surveys show 30 to 40% wouldn't choose their profession again. And if you're asking how would they recommend it to their children, 90% of doctors wouldn't recommend medicine to their children. So in the end, I asked myself, how will this battle affect the overall healthcare system? I fear we won't see the forest for the trees. And this is simply a symptom of a bigger disease, a system that, quite frankly, of healthcare that is broken. I appreciate the conversation. I wish, quite frankly, this could be a 2-year bill, that we could actually have a joint legislative hearing on this issue or a special select committee to talk about this. But we're not going to be able, I don't know that we have that opportunity. But the conversations on both sides are so big and so monumental and so potentially damaging to so many that we're being asked to move something forward here. And if I vote for this today, it will only be to keep the transparency conversation going, and I too would reserve the option to not vote on the floor. This is a really, really challenging issue, and like I said, there are no angels, there are no devils, but there are winners and there are losers. And I wish that we could get everybody in a room and have these conversations rather than duking it out through a bill. Thank you.
Thank you, Assemblymember Wood. Assemblymember Mainshine.
Thank you, Mr. Chair. Having served in a district with one of the largest biotech clusters in the state, and both as a San Diego City Council member and now as a member of the Assembly, I've worked on these issues for a number of years, and certainly found this industry is really unlike any other that we have in our state. Certainly the biggest cost driver is to get a drug to market and approved by research developed, approved by the FDA is so time intensive and so costly. We know that about 95% of the drugs that are experimented on and initiated fail to make it to market. A company hoping to get a single drug to market can expect to have to spend about $350 million before the medicine is available. And in part because so many medicines fail, companies that have multiple drug projects in the work spend huge amounts of money, estimated sometimes up to about $5 billion. I'm concerned about a number of issues here, one of which is even how you would attempt to delineate how the research was developed. And just as for an example, if you have a company that was researching a drug for say, kidney cancer, and found out part of the way through that the drug wasn't working for that, but it might work for a bladder issue, or might work for a separate issue. How would they account for those differences? And I think that would be pretty problematic. I also am concerned, it was brought up earlier about cost of drugs for other countries. Certainly these other countries are operating in circumstances much different than ours. For example, many have single-payer systems, and while this may reduce costs, survival rates and other results are significantly less as well. Secondly, through compulsory licensing, some countries really will just steal or threaten to steal patents of these companies, again, not operating under the same set of patent laws, the same set of research drivers and innovation drivers that we have here in our country. And so on some level, we pay more on the introduction end of a product, but other countries pay more over the life cycle, or over the end, not over the life cycle, over the end of a product life cycle. And I too have struggled with this, like Mr. Wood. I have a personal, certainly, like probably many members up here, I know my mother is a 3-time cancer survivor, and would not be here to be around, not just for me, but for my daughters, if it wasn't for some pretty extensive and remarkable innovations that happened that kept her around. And so on a personal note, that's something that certainly enters into my line of thinking. I know, too, that spending on prescription medicine isn't all of the costs. We've looked at a more significant rise in administrative costs, and I think something, while certainly the drug costs are obviously significant, I think it shouldn't go without noting that the administrative costs have risen at an even more rapid rate. Now we have nearly 90% of all prescriptions being generics. Medicines, these medicines are perhaps the only part of the healthcare system where over time prices actually go down as these drugs enter the generic market. And in terms of transparency, these pharmaceuticals really are among the most heavily regulated industries in the healthcare sector. Manufacturers throughout the process provide a really significant amount of information on drug effectiveness and safety simply to get through the FDA approval process, as well as was mentioned earlier, I think, with SEC requirements for the larger, for the more public traded ones. In order also just to be consistent, I did oppose SB 746 last year, involving the plans and some disclosure processes that were proprietary in nature, and I do want to be consistent with my earlier vote. And I would just conclude with this. In 2013, Americans spent more than $200 billion to support administrative costs of insurance, and versus $270 billion on retail medicines that provided patients with life-saving treatments for diabetes, cancer, HIV, cardiovascular disease, and a host of other medical conditions. So I won't be supporting the measure today. I do also, Mr. Chair, I want to thank you. I have enjoyed working with you. I've enjoyed our discussions on this over the weekend as well, and hope to continue to work on this in not just this term, but in the terms ahead.